Okay. Good morning, everybody. I'm going to talk about menopausal hormone therapy, and I'm titling it, Is the Pendulum Swinging Back? Because I think it kind of is, and I think that's really a good thing. I have no disclosures. Objectives. My objectives for this talk are to help convince you to start putting women back on hormone therapy or putting them on hormone therapy. When I say back on hormone therapy, I'm thinking back to 1992. But let's talk about now. I think we should be putting more people on hormone therapy. And one of my objectives of this talk is to help convince you that that, in many cases, is the right thing to do. So I was going to use a pendulum, but I thought it was more complicated than a pendulum. So I found Newton's cradle balance balls, but I didn't think that sounded so good in a title of a presentation, so I figured I'd add it in now. Back in 1995, when we had all the data about the huge cardiovascular benefits of hormones, we put everybody going into their menopause or right newly into menopause on hormone therapy. 40% of women were on hormone therapy at that point. In 2002, when the WHI results came out, we pulled everybody off their hormone therapy. And that was because of the increased risk of cardiovascular death. But even that was coming out of the WHI, but even at that point, 12% of women were still on hormone therapy. Now, I'm going to call it cardiovascular variable. However, we still only have 5%. So we have less people on hormone therapy now than back when we thought it was going to really do them harm. So I'm going to just do a little history of hormone therapy. Dr. Robert Wilson, he was a heck of a guy. He wrote this book, Feminine Forever, and these are some of his quotes, and these will be my quotes of the day. Breast and genital organs will not shrivel. This is if you take hormones. Women will be more pleasant to live with and will not become dull and unattractive. So it gets better. Instead of being condemned to witness the death of their womanhood, they will remain fully feminine, physically and emotionally, as long as they live. And menopause is curable. So right away, that makes it a disease, and as we can see when we look over some of the data, treating it as a disease is what got us into trouble in the first place. Here he is. He looks like a super stud to start out with, so I can see how he has judged all of the women around him, and those are my quotes of the day. So let's go back to the 1980s, and everybody raise their hand if they actually dressed like that at some point. In the 1980s, all of our data was based on observational trials. So we were looking at people who were on hormone replacement therapy and seeing what their outcomes were. And we were finding fewer heart attacks, improved coronary vasodilation, fewer strokes, stronger bones, less osteoporosis, and improved cholesterol. So it seemed like the best thing that there is. In 1995, there started to be a lot more randomized controlled trials, and they confirmed what the observational trials showed. They had lots of coronary benefits, they had cholesterol benefits, they had anti-inflammatory properties, and so everybody thought, okay, here we are, we put everybody on hormone therapy. What happened next was the Women's Health Initiative started in 1993, and it ironically was sponsored by Wyeth, who are the people who make Premarin. And what they were trying to do is they were trying to get FDA approved for a cardiovascular indication. So they were trying to make it that hormone therapy was something we gave people to prevent cardiac disease. The problem was it was terminated early in the estrogen-progesterone arm in 2002 and in the estrogen-only arm in 2004. And that was because they found an increased risk of a cardiac event in the first year of use, higher breast cancer risk, higher risk of thrombotic event, and increased risk of stroke. When you look at that, what the first column made all the newspapers and all the headlines, and everybody heard about this, but nobody ever really looked at the actual increased risk, which was very low. So when we heard that, everybody came off their hormone therapy. But everybody continued to have menopausal symptoms, right? Just because we decided we can't treat menopause didn't make menopause go away. So we have the hot flushes, the vaginal dryness, and then the even less treatable and more annoying weight gain, sleep disturbances, moodiness, sexual desires, joint aches, all menopausal symptoms. Not to mention, we all know the menopausal health consequences. Osteoporosis, we know cardiovascular disease increases after menopause, and you have an increased risk of metabolic syndrome. So what happened? Women were not being treated. We tried to look for all kinds of alternative things to treat the menopausal symptoms, none of which really worked as well as estrogen. In 2012, our only FDA-approved indications for hormone therapy are hot flushes, urogenital atrophy symptoms, again now known as the, I'm blanking on it, genital something of menopause, GSM, I'll think of it. And for bone health maintenance, but not as first line. And I don't know that anybody's really using it for bone health maintenance at this point because there's so many other good things. I think that's a nice side effect of it if you're using it for hot flushes, which is what we mostly use it for. They also recommend lowest dose, shortest duration. And that really limits us in our flexibility with women. Menopausal hormone therapy has never been FDA approved for cardiovascular protection. Again, that was something Wyeth was trying to go for, but never got to. In fact, they went just the other way and probably plummeted. They actually did plummet their Premarin sales. It's not FDA approved for any of the other menopausal bothersome symptoms. Hot flushes are a huge problem. They occur in 75 to 80% of postmenopausal women. They last an average of 4.9 years, which is very convenient when we talk about that 5-year risk of hormone therapy. However, up to 30% of women continue to have hot flashes for 10 years after menopause, and 8 to 9% of them were still having hot flashes at the age of 72. So fully more than 20 years after menopause, there are still women who are having hot flushes. And I know I have a lot of those women in my practice. I'm sure you do as well. So I'm going to convince you in 2018 that what we do is we don't look to put everybody on it. We don't look to put nobody on it, but we look at the people in between and say that we can select and put appropriate candidates on it. Estrogen will, for vasomotor symptoms, decreases hot flushes by 75 to 80%. I think the most interesting part of this slide, versus 50% placebo. Hot flushes respond really well to placebo. So it's hard to find something that works better than placebo when placebo works 50% of the time. So that's why there's a lot of, not studies, but there's a lot of information out there that says vitamin E works and magnesium works and all these other things work because they work 50% of the time. But they're not doing anything different than your placebos are going to do. And when you actually try to head-to-head them with placebo, they're not any better. Hormone therapy for vasomotor symptoms needs to be systemic. And in most women, the benefits are going to outweigh the risks. Why don't we prescribe estrogen? I know we're not chicken because we do a lot of things, we give a lot of medications, we take care of a lot of people, and for those of us who are OBGYNs, we cut people open and sew them back together. So we're not afraid to do things. It's not that we don't care. It's not that, is it or is it that we just don't want to be bothered? Is it too much of a problem? Does it take up too much of our time? And even if the answer to that is yes, that doesn't mean we shouldn't be doing it. But I think we're all stuck in 2002 and we're all still worried about the cardiovascular disease. So these are the Backstreet Boys today. So they've moved on and so must we. Why should we worry about cardiovascular disease? Well, it's 1 in every 4 female deaths. And this statistic surprised me that the same number of women and men die each year of heart disease in the United States. I got that off of the National Statistics Report, and that means since men start having heart disease earlier, women seem to do a good job of catching up after menopause, and that really surprised me. And even more than that, the leading cause of death in both white and black women is heart disease. In Hispanic, it's about equal to cancer. And apparently, if you are of an ethnicity that begins with the letter A, you have a higher risk of having cancer than heart disease. If you look at the map, all of us in this room are in a high heart disease area. And I'm sure we all already know that. So are we doing all we can to help women with heart disease? Again, 2012, the WHI was reevaluated. This is not news to most of us in the room. They stratified it by age and duration of menopause. And what they found was that women between the ages of 50 and 59, basically less than 10 years out from menopause, had reduced mortality with hormone therapy. And total mortality in that group decreased by 30% over the course of that study. Statins and aspirin in the same age group had no decrease in mortality. I don't know if that's still true if there are some of the newer drugs. So I think we all have to say goodbye to 2002 and get into 2018. There are a couple studies post-WHI that unfortunately don't get as much news coverage as WHI did. And the KRONOS, the KEEPS trial, was only 4 years, 700 women. So not as, the WHI was thousands, multiple thousands of women. Is less than these women though were less than 3 years from menopause. Remember in the WHI, the average age of women going into it was 65. So they were already more than 10 years past their menopause. That's when I think we were treating menopause at that point as a disease, and estrogen was a medication. It wasn't a replacement. If you haven't had something in your body for 15 years and then you put it in, that's more of a medication than a replacement. Okay, there's too much of a dip in between there. So, and they actually selected their women a little bit better. They took out the people who had a lot of cardiovascular risk factors. And they put them on either CEE is a conjugated equine estrogen, hence Premarin, or 50 micrograms a day of transdermal estradiol plus oral micronized progesterone, 200 milligrams daily for 12 days a month versus placebo. And what they found was not that there was tremendous improvement in cardiovascular health. They kind of found a neutral effect. But if you're giving it to somebody to treat hot flushes, a neutral cardiovascular effect is kind of okay, right? We're not trying, be nice to treat some of the cardiac, prevent some of the cardiac disease, but if we're not hurting it, then that's also a good thing. What was important in this trial is there's no significant difference in breast, endometrial cancer, heart attacks, strokes, or thrombotic events, which that was a little surprising to me, but again, they had a low-risk population. It was only 4 years. Okay, the breast cancer risk tends to go up after 5, and some of those other cancers, they were still fairly young women. So I think that kind of skewed that data, but it is reassuring. There was a Danish osteoporosis prevention trial where they had a little bit more women, 1,000. They were aged 48 to 58, so again, within that 10-year frame. They had estrogen and progesterone variable formulations, and they reviewed them at 10 years and 16 years. So that has much longer time frame behind it. Their primary outcome was osteoporosis, which was decreased because we know that. But they did find reduced overall mortality, reduced heart failure, heart attacks. They found, again, no added cancers, no added strokes, and no added thrombosis, which surprises me a little bit because I do think we are probably increasing those a bit. But again, more reassuring data when we look at the right population of women in terms of hormone therapy. Meta-analysis, the Cochrane Review of 2015, less than 10 years from menopause, and this is both estrogen and estrogen progesterone group. Coronary heart disease does decrease, thrombosis increases, which we already knew. The cardiovascular, CVA strokes was neutral, and there was, again, 30% decreased mortality overall. Why is it that the younger women do better with the hormone therapy? Just because hormone is doing what it's supposed to do. It is dilating the coronary arteries, it is making them more pliable, it is changing your cholesterol so you don't build up plaque. Why is it not good in people who are more than 10 years out? Because they already have plaque. So if you take an artery that has plaque in it, estrogen's gonna hurt you in two ways. One, you dilate the artery and the plaque gets released, goes to your heart or your brain. Two, estrogen is prothrombotic. So if you have plaque in your artery, you don't have that smooth blood flow, you get platelet aggregation in that area and you make your clots. So that's why if you have not normal vessels to start out with, then you are not going to help them if you add estrogen, and you are going to potentially hurt them. So it's come back to the timing of hormone therapy, and it's called the timing hypothesis. If you give the hormones immediately after menopause or during perimenopause, if women are symptomatic, then you're going to get improvement in symptoms without increasing cardiac risk and probably increasing cardiac benefit. So 4 good reasons to start it right at the time of menopause. Well, this is when the symptoms occur. So this is when you want to treat the hot flushes. Initiating it within 5 years of menopause probably still has cardiovascular benefit versus risk if it's more than 10 years out. And the breast cancer risk in combined therapy, again, when we start teasing out the estrogen plus progesterone, it gets a little bit more confusing. But if you have estrogen plus progesterone, and most of the data is on Premarin and medroxyprogesterone or Provera, then your breast cancer risk increases after 5 years of use. And again, remember the average duration of vasomotor symptoms is 4.9 years. So hopefully we've treated the symptoms, we've not increased cardiac risk, we've given some cardiac benefit. And then yes, if they're not symptomatic anymore and they choose to stop after 5 years, then I think you need to counsel them about the risks and benefits. And after 5 years, if they want to continue, I think it's fine for them to continue as long as their risk factors haven't changed. So I said there are 4 good reasons, and those are only 3. The 4th one is about cognitive function. That was the other problem that came out from WHI and some of the other studies, right? We thought estrogen was making women have a decreased risk of dementia and Alzheimer's disease. And then we started seeing this data saying, no, they're getting a worsening, more higher incidence of those disorders. And that's not good either. So they have, when looking back at the studies, very similar to the cardiovascular studies, they have the critical window theory. And the critical window theory by the neurosciences has been developed by the neuroscientific community. It's basically the timing hypothesis on Alzheimer's disease. So it's basically what I just said about cardiovascular disease. We can just think back of everything I said and apply it to Alzheimer's and dementia, and we get the same result. Observational studies showed decreased risk of Alzheimer's 29 to 44. Why are observational studies so different? Because they're women who were placed on hormone therapy by physicians at the time of menopause. So they come in, they have symptoms, you put them on hormone therapy. I had the benefit of coming out of residency in 1992, and we put everybody on hormone therapy. Every person who walked into the office. I had patients, and again, in retrospect, I was lucky. I would have patients who came in at the age of 75 and say, I just had a heart attack. Is there anything you can do to help me? And I'd be like, yeah, let's put you on hormone therapy, and this is going to really help you. Everybody was on it. What? Everybody did that. And I think the residents today, I do an interactive sessions with the residents every other week, where we meet for an hour and I cover office gynecology, because they don't see the same population in the clinics. They tend to see the younger people in the clinics and less problems. So I do office gynecology, and I always ask them what they want to talk about. They always want to talk about hormone therapy. None of them have ever given hormone therapy. They're terrified of hormone therapy. They also always want to talk about osteoporosis. So osteoporosis and hormone therapy is what they want to talk about most in those rounds. They don't care about the abnormal bleeding, anything else. That's what they want to talk about. I feel like I talk about it every other week. But anyway, the observational studies for Alzheimer's show the decreased risk. WHI memory, funny how I can't remember that. WHI memory study and dementia. That was part of the WHI. The memory study from the WHI was looking at dementia in that population. What they saw was a combination of the estrogen and the medroxyprogesterone. The risk doubled. And with estrogen alone, there was no change. However, they said they looked at it over 4 years and said it was not statistically different. I don't know how something could double and something could not change and it not be statistically different, but be that as it may. Then they went back, and it was the WHI something cognitive assessment. I was trying so hard last night to remember those. And what they found was they were looking at verbal memory. And why is verbal memory important? Verbal memory is important because it's been shown to directly correlate with declining cognitive function and increased risk of dementia. Okay, so verbal memory is I tell you something and you have to repeat it back to me. Okay, and they said with the combined estrogen progesterone, verbal memory decreased, which again is the same marker, and with estrogen alone there was no impact. So what they showed was very consistent. Estrogen plus progesterone was not good. Estrogen alone was probably neutral. There has been since then other studies that have looked at cognition and hormone therapy. There was a very large Kaiser study 5,000 women, again, not large compared to WHI, but bigger than some of the others we've looked at. They said if you started hormone therapy at midlife, and they were defining hormone midlife as around that 50, so again, you're going to be in that 5 to 10 years from menopause, they saw a 26% reduction in Alzheimer's disease and dementia. And if you started it later, meaning more than 10 years, you had a 46% increase. Mirage study with Alzheimer, again, women aged 50 to 63, decreased risk. The Cachet study, hormone therapy within 5 years and continued for 10 years had a 30% decreased risk of Alzheimer's. After 5 years, estrogen alone, if you only used estrogen alone, you got no increased protection. So they're actually saying that 5 years wasn't helpful, that you had to go out to 10 years for it to be helpful, although some of the other studies did not keep women on it for that long. But again, if you had the estrogen and progesterone together, you had a twofold increase. So we worry that there's something about the progesterone. Most of these studies were using medroxyprogesterone. The KEEPS trial, the KRONOS trial that we were talking about earlier, basically had no effect on cognition with the early intervention group. But remember, that was only a 4-year trial, 700 women, 4 years. So why do they think that happens? The critical window theories goes down to basic science when you look at mitochondrial function. With estrogen, mitochondria metabolize glucose. Okay, that's normal, that's what they're supposed to do, we metabolize glucose. Without estrogen, they tend to metabolize more ketones, and that leads to a byproduct of amyloid. So imagine if you're getting amyloid deposition in the brain, that is going to increase your risk of Alzheimer's. They also, just like the cardiovascular data and the breast data, there's a suggestion that it's not developing new disease, but it's just accelerating the existing neuropathy, again, that women have already started when you get 10 or 15 years out of menopause. That there might be increased ischemic mini strokes in the brain. Again, you've got little vessels, you've got thrombotic tendency with estrogen, you may be clogging off small vessels, although MRI data does not support that. Cognitive domain most sensitive to estrogen in either a negative or positive is, again, verbal memory, and like we said, that is the most sensitive predictor of dementia. In women, in general, verbal memory does not start decreasing until age of 55. So again, you have to start thinking, is there an estrogen connection there? So the theory, and again, those are theories. Okay, I'm not saying that's why it's happening, but people are still looking at it to try to figure out what is it that we're not seeing that we can influence. So there's a theory that 2017 EU-ESTROGENEMIA, which they said was a unifying theory, that it put together the timing hypothesis, the critical window theory, explained the randomized control trials, clinical observations, basic science of estrogen receptors. Now, the EU-ESTROGENEMIA theory, we can all guess what it is, can't we? The true and good concentration of estrogen at which more than the 3,600 ubiquitous estrogen receptors function optimally and continuously. So basically, they're saying there's a level of estrogen that is the good level of estrogen, and all those receptors work the way they're supposed to and do all the good things that estrogen is supposed to do. They believe that it's all related to the estrogen receptor, that the estrogen receptor is variable and time related. So if you stop feeding the estrogen receptor estrogen, there is a basic physiologic change in the estrogen receptor, and then when you give it estrogen back after a period where you don't have any estrogen, that estrogen receptor never goes back to function normally again. Same thing with the mitochondria. Again, is there a lot of science behind this? It's just out there. I thought it was interesting, so it was worth talking about. It's something different, right? They called it Jerry-pause. I don't know why they called it Jerry-pause, but you know, they wanted to invent a new word, and there you have it. They say their evidence is that in monkeys, after a period, and rats, after a period of hypoestrogen, the estrogen receptors change configuration and don't respond the same. The mitochondria, the same thing. Once they stop reacting, metabolizing glucose and start metabolizing ketones, that it's very hard to switch them back. And the theory is that to maintain this optimal estrogen receptor function requires ongoing estrogen exposure. And they think that that is why estrogen needs to be started right at menopause. I think there's clinical data that shows it. I'm not sure this basic science is so convincing, but it is really interesting, and it's good that people are still looking at it. So in 2018, less than 10 years from menopause, that's the population we should be looking at. So what's stopping us? Usually breast cancer. Breast cancer is everybody's biggest fear. And it's hard to convince people not to be afraid of breast cancer. I'm afraid of breast cancer. We're all afraid of breast cancer. However, we're more likely to die of other things than breast cancer. And even if you get breast cancer, you're not really likely to die from it, especially after menopause, right? Most people diagnosed with breast cancer don't die from their breast cancer. And it's something that can be screened for. We'll talk about that tomorrow. That'll make all of our heads spin. And if you look at the 13-year follow-up in the WHI, it was only in the estrogen and progesterone group that you had the increased risk of breast cancer. It was not in the estrogen group alone, and not until 5 years of use. So that should be reassuring to people. Other cancers, ovarian cancer, again, if there is an increased risk, and there's some data that there is, it's less than 1 in 1,000, and the absolute risk per woman is very low. And it doesn't increase the risk with family history. So if you have a family history, or even if you have BRCA, you're not increasing that ovarian cancer risk by giving estrogens. Colon cancer, in the observational data, it was preventative. And in the WHI, even in the stratified, there was not strong evidence either way. Lung cancer is neutral. There was some grumblings about it increasing lung cancer, but that again turns out to be neutral. So what about the other things we talk about? Well, it helps sleep, it helps bones, it helps prevent diabetes, new onset of type 2 diabetes. It's not good for the gallbladder or liver, we know that, the same as combined oral contraceptives. It's the estrogen effect through the liver. Can we reduce that a little bit? We can, and we'll talk about that in a minute. Cognition and dementia, I'm putting it down as a neutral. Again, I think that is based on your patient population and your timing. And mood, I put probably, there are some studies that show that it does increase mood, and I think probably the increase in mood is secondary to the overall feeling better. You have less hot flashes, you're sleeping better, your bones don't hurt, you feel better, so you just get into a better mood. Again, progesterone, the enemy, may contribute to mood disturbances. And what's sad is, we do so few hysterectomies anymore that we have to give everybody progesterone. In clinical trials, again, I'm just putting that there, cases per 100 women in the 50 to 59 year age group versus no hormone therapy, and what you can see, most of them are negative values. The breast cancer is increased in the estrogen and progesterone, but not estrogen alone. We always knew that the breast cancer risk went up. Stroke, in the first year of use, in all users, the risk of stroke is increased. Thrombosis, we always knew about thrombosis, and again, ovarian cancer is a very small increase risk. So all pooled data, estrogen and progesterone and estrogen alone, cumulative risk of mortality 18 years out in WHI in that age group. And the age group of 50 to 59, decreased mortality. 60 to 69, pretty neutral mortality. Once you hit that 70 to 79-year-old, more than 10 years out, you're increasing mortality, but it's not tremendously increased. So risk increased with increased age at randomization. So let's decide, yes, we're gonna give hormone therapy, right? We're gonna run home and give hormone therapy. Well, maybe. Let's figure out how we're gonna give it. We have a decision tree. You have a woman who's symptomatic with hot flushes, bothersome hot flushes. Make sure you write the word bothersome in your notes, because that's the FDA approved. Yes, she has them. Does she have any contraindications? We know the contraindications. No, she has no contraindications. Let's look at her cardiac risk, because that's going to be our major focus. Breast risk, we need to look at the breast risk too, although there are no current recommendations on when is that breast risk acceptable. So for the breast risk, the Gale model, we all know the Gale model, it's not perfect, but it will, we have an app for that. So again, we can pull out our phone, we have an app, we can calculate the risk of breast cancer. Low risk is less than 15% over a lifetime. So if somebody comes out less than 15%, that's pretty reassuring. Even if they come out in the moderate risk, we need to just have a discussion with them about it. Framingham cardiac risk score, yesterday when you were talking about that, I was sitting there holding my breath saying, please let them say it's the Framingham that they want to use. Again, you are probably the internist and general practice, well, everybody but the OBGYNs are probably much more familiar with this than we are. but it comes out, you put in your data, and you get your total risk. Very low is less than 5, low is 5 to 10. So you want to look at the menopause decision. Is she somebody who is good for estrogen? Does she have a low cardiac risk score? And then you can continue to make your decision. So significant, again, let's go down this risk. And if you look at it this year, less than 5 years or less than 10 years from menopause, with a very low risk or a low risk of heart disease, it's probably okay. If there's a moderate risk of heart disease, a little bit more conversation, but if they're less than 5 years, hormone therapy is probably okay. If they fall into the high risk, it's probably never okay, and if they're greater than 10 years, you should not be starting hormone therapy at that point. So if only we had an app to put all that together. We do. It is the North American Menopause Society has the MenoPro app, and what it will do is it will ask you menopause questions. It incorporates the Framingham study questions. You put that all together, and presto changeo, you get the answer as to what the risk is and whether or not this person is a good candidate for hormone therapy. So we decide yes, which hopefully we're doing a lot. Standard dosage are kind of the traditional dosages. Again, conjugated estrogen was 0.625. We were at a milligram of micronized estradiol. There's low dose and there's ultra low dose. Interesting, the ultra low dose has a very variable efficacy for hot flushes. They're not actually FDA approved for hot flushes. They're FDA approved to prevent osteoporosis. Again, I don't know how many people are using it for that indication. A lot of people are giving the ultra low dose to treat hot flushes, and I don't think that's doing women a good service. If they're still suffering from hot flushes on a low dose, you need to go on a higher dose. I usually start on the medium. Sometimes, depending on their age and their symptoms, I will start on the kind of standard doses or on the low dose. But if people are not getting well treated, if you're giving them estrogen for benefit, they're still getting the risks of estrogen, so you might as well give them enough estrogen to give them the benefit. And if you give somebody an ultra low dose and they don't have relief of symptoms, they're not going to continue to take it. My theory, again, this is opposite what the FDA says. I think you should start higher and go lower, because you want to treat them, and then if you bring them back after 3 months and they're feeling really good, you can talk about, let's try one dose down and see if that still makes you feel better. In my mind, if they're not getting treated, they're not going to take it.
And you're talking about estrogen, now you're just going into progesterone. Or when you say hormone therapy, are you talking about both, or do you differentiate? I'll talk about progesterone now. I was talking about estrogen just then. Dosing of progestin, we all know that it could be cyclical or continuous. There's not a great reason to put people on cyclical unless they really want to continue having a period. You can do it with medroxyprogesterone, norethindrone, or the micronized natural progesterone at those doses. Does it matter? Estradiol, when they teased out in the studies, estradiol may be a little bit better anxiolytic and antidepressant, kind of better for mood than the conjugated equine estrogen. And the micronized progesterone may have less breast cancer risk, may have less cognitive impairment, may have less of everything, but that data isn't out there yet. There are some really good early studies showing that the micronized progesterone is a better way to go than doing the synthetic progesterones like medroxyprogesterone. Why do I have a picture of peanuts there? Everybody knows micronized progesterone is in peanut oil. So if somebody has a peanut allergy, you cannot give it to them. Okay, I have a son with a peanut allergy, so I'm particularly sensitive to that. Alternative to the systemic progestin, the levonorgestrel IUD. It's not FDA approved for this indication in the US, although it is overseas. There are 2 meta-analyses of the Mirena, the higher dose one, with estrogen therapy that said it was as good or better for protecting than systemic progestins for preventing endometrial hyperplasia. So you can get protection with a Mirena. Mirena is a great thing to do when people come in their perimenopause and they are having irregular periods, because that's when insurance will pay for it. And then you get it in there and you have at least the first couple years of their menopause that you can give them the estrogen only, although some of the data coming out on the progestins in the Mirena are also starting to be a little bit concerning for some of the breast cancer and other things, although that's very preliminary. You can do the selective estrogen receptor modulators, which is conjugated estrogen, and the selective estrogen bazodoxifene. The benefits, that tends to have less breast tenderness, less progestin side effects. It does protect the endometrium. Blood clots, I always worry that you have an additive risk. It does not seem to be additive from both the estrogen and the SERM together. And in breast, it's likely neutral, and long-term data are not yet available. So it may be protective for the breast, which would be a good thing, and it may be better. It is probably better than using a synthetic progesterone. The current dosing suggestion by both ACOG and in UpToDate is that you use a transdermal estradiol with an oral micronized progesterone. Again, based on some of the data with the medroxyprogesterone, and the estradiol based on some of the cognition mood things that are coming out. How do you dose it? Well, again, why? Least thromboembolic combination. If you go transdermal, you bypass the first pass through the liver, so you have less effect on liver. And again, there's new data emerging showing that it's a better breast cancer profile. So this is what I keep next to me in my office, because now I can't remember all the different hormone therapies. So I keep a list of all the different hormone therapies in my office, and when I have somebody who wants to be on it, consider uterus present or absent. What does the patient prefer? I can tell them you need to use a patch and a pill, and they'll say to me, I don't want to use a patch and a pill. That's really annoying. I have sensitive skin. I really don't want to do that. That's okay. Put them on the oral. Just talk to them about this may be a little bit worse for your liver. It may not give you as much benefit in your lipids, but that's okay. If that's what you want, we're treating your hot flushes. And if I don't give you something you want to take, you're not going to take it. Medical history, again, paramount of importance. Insurance coverage, usually not too much of a problem, although I do find that insurance prefers to pay for pills over patches, which is also an issue. Look at, again, how likely are they to be compliant with the treatment. The other take-home message, people come in, and we all know this, they come in for their general exam, they come in for their annual exam, and what do they say? Well, I made this appointment because I'm having hot flushes, so can you do my PAP and put me on hormone therapy and counsel me about everything else in the world? Having to have that lipid profile, having to really spend time, people really need to come back for a separate appointment to talk about hormone therapy. I have tried to do it in a single appointment, and I admit sometimes I have, and I'm probably not even doing the best job of really teasing out that cardiovascular risk. And I think we really need to pay attention to that. So look at the women. Let's not look at them as Newton's cradle balls. Let's look at them as women that are actually suffering, who we can really help. And that's me having a hot flash. Any questions? Questions? Right, somebody has to throw the box. And remember, we're going to have the panel. That's why we're going to have the panel in a little while, which we're all going to talk about different menopause from different perspectives, which I think is going to be really interesting. And that's why I wanted to give this talk first, so that we didn't spend all of our time on talking about hormone therapy.
If you take estrogens, it doesn't really influence your testosterone levels generally. And so you didn't talk about testosterone treatment in your talk.
I did not talk about testosterone treatment. That's true. There is no FDA-approved testosterone treatment in the US. That gets you into the discussion about bioidentical hormones, and people always ask me about bioidentical hormones. I will prescribe bioidentical hormones under duress if I'm really pushed by a patient or if a patient comes in and is already taking them. I will try to talk them out of them. I don't like to prescribe testosterone. I know there are a lot of people who really believe in it. I would love for there to be an FDA-approved testosterone with good guidelines and recommendations, and then I would use it. But I, at the present, don't use testosterone.
And if you, I'm sure you've seen patients because we're close in age, not quite, but anyway, so that they come in and they're 65 and they've been on it since menopause, would you allow them to
They've been
continue?
on what?
Estrogen.
They've been on estrogen and they're 65 and want to continue?
Yes.
Yes, I would absolutely let them continue.
I'll try one other one, Nancy. Thanks for the presentation. What about, because I see a lot from the patients I take care of in my age range, that 61, 64-year-old women who, you know, we have ignored over the years a little bit and it's been off because of all the studies. And now they're coming in basically with the dyspareunia and the other problems, and they're, you know, not that comfortable. I know it's not the topic that you're working on exactly, but I don't want to abandon that patient either.
No, I think that the way I look at it is I look at it from the time, if they've been off hormones for less than 10 years, I treat them as 10 years from menopause, still looking at their cardiovascular. So if they're the group of women that took hormones, you know, it's 2002, so we're getting past that 10-year, you know, we're past that 10-year mark. But if somebody comes in, and I see this a lot, they'll say, I was on hormone therapy for 15 years, I was so happy, I loved it, and 5 years ago my doctor told me I had to stop it. And that patient, I still consider them, again, this is my consideration, not the recommendation, but I still consider them within 5 years of estrogen exposure. So I don't feel like I'm introducing a new drug to them, and I will start them back up on estrogen. In terms of dyspareunia, you don't have to have systemic estrogens for dyspareunia. And the vaginal, locally applied vaginal estrogens are really good for dyspareunia, and I recommend them. I also am so excited that Intrarosa has been FDA approved. You know, Intrarosa is DHEA. Getting back to testosterone, why do I like Intrarosa? And again, my disclosure is I have been on their board, but I do not have any stock or any interest in them. I was on their board because I approached them because I was so excited about the product. The reason I like it so much is because it converts first to testosterone, then it converts to estrogen. So you are getting the benefit of both. And right now, they're actually doing studies to see if Intrarosa is going to help with some of the desire disorders, because that came out of their original trials, that they had an incredible improvement in their dyspareunia and their vaginal dryness, but a lot of these women also said they had increased desire. So right now they're trying to tease out, was that a secondary or a primary increased desire? Because your testosterone levels don't really rise that much, so it's hard to say if it's a testosterone effect. I particularly like it because my primary area that I work in is vulvodynia vaginitis, vulvovaginal disorders, and I find for my vulvodynia patients, the Intrarosa is working really well. And again, remember, the vulva has a lot of testosterone receptors on it. And the biggest side effect of Intrarosa is vaginal discharge, and I love that vaginal discharge because it's getting the product out to the vulva, which is where I want it to be.
That's one response on the Intrarosa.
Yes.
The only problem with my patients has been the expense.
They have coupons.
They don't work.
They don't work.
Commercial insurance.
Well, Medicare, well, you know what, get in touch with your Intrarosa rep, because Medicare has now accepted it, so Medicare will now approve Intrarosa. Sometimes you have to jump through hoops for it, but if you have problems with payers, if you get in touch with your rep, they will actually work it out for you.
There's a couple other mechanical things you can do too, like there's vaginal rejuvenation with Mona Lisa or Thermiva, which works really
Yes,
well.
right, Mona Lisa and the other
Thermiva.
vaginal rejuvenating products. There's been some data saying that, again, short term they're good, long term they may not be as good, but I think that's still an emerging treatment. And I do see people who have a lot of great response to it. Unfortunately, we don't have one. I've been arguing for one for years now, but by the time it gets through all the bells and whistles I need to go to, there'll be something new anyway.
For women that are greater than 10 years out and are still having very severe hot flashes and have never been exposed to HRT, do you have a go-to non-hormonal treatment that you would recommend?
Well, the non-hormonal treatments are the SSRIs.
Right. You have a specific one that you...
Brisdel, they're not fantastic, but Brisdel is the one, it's Paxil, it's basically a lower dose of Paxil. It's 7.5 as opposed to 10. I have a hard time getting insurance to pay for Brisdel, so I just put them on 10. You can use gabapentin at high doses. Actually is as good as estrogen for hot flashes, but people don't tolerate the high doses of gabapentin very well. Sometimes it's a hard question. It's a hard, when they're more than 10 years out, it's really hard. If they're really suffering and you talk about the risks and benefits and they're healthy and they don't have evidence of cardiac disease, you can talk about giving them the low dose. You know, in that population, I would start with the ultra low dose and see if I could get them at least a little bit of relief.
Okay.
So I don't absolute contraindicate it, but it takes a lot more counseling.
If I could just interject, you can use self-hypnosis for hot flashes. Really very effective. We have some people in the Mind Body Institute supported by the NIH right near us, and they have an 85% reduction in hot flashes if you practice their self-hypnosis. And they started out doing this in tamoxifen-treated patients who have horrible hot flashes. And again, they also had an 85% improvement. So if there's somebody in your area that does self-hypnosis, that's really an excellent way to have these older people who you're worried about estrogen be on.
Oh, thank you. I was not aware of that. I know cognitive behavioral therapy kind of helps with them as well. Maybe it's more of a self-hypnosis. Another question?
Here it is.
I downloaded the NAMS app, and when I saw that you had to enter all the cholesterol information, of course that complicates it because as an OBGYN, you often don't have access to that information. Do you get a lipid profile on all these patients before you put them on HRT?
If I don't have a lipid profile, I do get a lipid profile. I don't do it, I have to confess, I do not do it for every patient. I look at the overall health of the patient, the BMI, the history. Most people nowadays kind of are a little bit aware of their lipids, but if I have somebody who's borderline or I'm worried about their medical history, I do. That's also a great way, we all know that, it's a great way to get people back for a second appointment. Say, wow, I'd really love to give you hormone therapy, I just need a couple of tests, let's do that and come back and we'll talk about it again, as opposed to, oh, I don't have time to talk to you about that today. I find people don't come back till next year, and then they complain again about their hot flashes.
I have a few questions. How long? Oh, I thought she was done.
Who's talking?
Me.
Oh,
How
okay.
long I have a couple questions. First of all, they never emphasize the problems with skin after menopause, total skin, like thinning or mood. I don't know if they don't study that, because when you go to the dermatologist, they'll say there's a 30% increase in the tissues, the skin and the overall body, which they come in and they complain about dryness everywhere. And they never talk that much about mood. And it seems that those are two big things. And do you ever use Wellbutrin in your menopausal women that complain of lack of sexual desire?
I have used Wellbutrin with variable results. For sexual desire is a very difficult topic. It's hard to treat. There is flubanserin out there, which is impossible to get insurance companies to pay for and is dreadfully expensive. Hopefully that will become less expensive. There's a new drug on the horizon that's an injectable that you use immediately before sex for increased desire. It's still not FDA approved, but hopefully it'll be coming soon. Wellbutrin has variable effects. I make sure that they are not having any vaginal dryness or other symptoms. Talk to them about, you know, desire in women is not always the primary reason for sex, and if when they have sex, sex is good, you have to kind of work on that. Intrarosa is a good also trial there for some of the testosterone effects. New data on flibanserin, which may make people want to pay for it, is in the women who have been on flibanserin, they've been showing a significant weight loss on flibanserin. So that may make people want to pay for it a little bit more.
How long do you feel like you get the say if someone's been on estrogen therapy for 10 years and they decide that the risk doesn't outweigh the benefits doesn't outweigh the risk, how long do you feel like they get a benefit from that therapy? Is that lingering, or is it gone once they...
I think when you stop taking the estrogen, you stop getting the benefits.
Okay.
What you've done is you've pushed back the
age.
decline in cardiovascular health, bone health, all that for 10 years. So instead of the clock starting at 50, now it's starting at 60. But it's going to continue to go.
Okay, I'll say one thing and I'll be quiet.
Okay.
But I'm a psych NP and family, but I do have a lot of good luck if someone is not really anxious and they can't take hormones and they come in and their mood's all over the place and they think their memory's bad, because Wellbutrin was the first ADD drug and the norepinephrine.
Right.
And so sometimes that will perk up their mood and in turn make them more interested in sex or more interested in everything. Not always, just a pearl if you like it.
Wellbutrin, okay. Yeah, I do use that. The other thing about SSRIs, Prozac and Zoloft, I know it's an SNRI, but in the SSRI category, Prozac and Zoloft don't seem to be effective for hot flushes. So,
Yeah, right here.
Can you please comment on the Mona Lisa for vaginal atrophy?
I can comment based on the data that I've seen, not on personal experience because we don't have a machine, but there are starting to be more kind of head-to-head trials with Mona Lisa, and it is showing good improvement. I think it's a very good treatment in select patients. It's rather expensive. I think in the breast cancer population, it's a great alternative. I think in women who have other contraindications to hormone therapy, it's a great alternative. I've seen people who have come to me after having Mona Lisa. The data is there. It's been used on thousands of women, and it has shown a good improvement in vaginal dryness. The problem is it's not a forever fix, and it's expensive, and you have to go average probably about, after the initial 3 treatments, probably about every 6 months to a year. But it's a good alternative, and there are other machines besides the Mona Lisa out there as well.
Got one more?
It's another guy naivety question. As a hypertension guy, clonidine and hot flashes. Has anybody had any experience with that? Because I've had to use clonidine in some women that are perimenopausal, and it's anecdotal, but I think there is some literature, although I'm not very
There is
versed.
literature.
But it helps, or at least it has helped.
We used clonidine for a long time, many years ago. I have not used it recently because, and it's more effective if you use it as a patch. So that it's a continuous, and there is good data that it reduces hot flushes, not as well as estrogen, and probably a little bit better than placebo. But there is good data on clonidine, and you can still use clonidine in select patients. The thing to remember is the orthostatic hypotension that people can get on clonidine. You can talk, as a hypertension guy, you probably have a lot more experience. As a gynecologist, it still makes me a little bit nervous. But it is also a good alternative.
Excellent, thank you.
Okay.